Hi there, it's 12 o'clock, so we'll get started with our webinar today. I want to just welcome and thank you for sharing your time with us today. We're thrilled that all of you could join us. My name is Jessica Stewart, and I'm a respiratory therapist and am chairing this webinar on behalf of the Ontario Respiratory Care Society. The Central Region Planning Committee has been hard at work putting this education session together. And we are so thrilled to have so many attend. I believe we have about 65 on this call who registered, so that's fantastic. During the pandemic, virtual care has been catapulted onto the scene in a big way. And as I'm sure our speakers will share, we have learned a lot both as providers of virtual care and also as recipients. So today we're going to be receiving pearls for practice from our expert panel. And the vision of the Ontario Respiratory Care Society is improved lung health through excellence in interdisciplinary respiratory care. And we certainly have an interdisciplinary panel for you today. We will be hearing from a physiotherapist, a kinesiology graduate who is also a registered cardiopulmonary technologist and a certified respiratory educator, and two respiratory therapists who are both also certified respiratory educators. So before I introduce our first speaker, I just want to go over a few little housekeeping details for today. After each speaker, we will have 5 minutes for questions, which can be typed into the Q&A box. There is a chat box and there's a Q&A box. So please put them into the Q&A box and I can ask the speakers at the end of their talk. And there will also be time at the end for questions for everybody after everybody has done their talk. And also this session will be recorded. So once it is archived, there will be an email link sent out to all who have registered so you can watch it whenever you like. Okay, so with that, I'd like to introduce our first speaker. Her name is Sandra Mirdell, and Sandra is the Director of Clinical Innovation with the Ontario Telemedicine Network. Sandra has several years of progressive leadership and management experience in a fast-paced, ever-changing healthcare environment. And Sandra has experience in healthcare planning, quality improvement, and innovative program development and implementation, with a focus on health and wellness, chronic disease self-management, and interprofessional collaboration. She has worked in partnership with many healthcare providers and organizations to co-design virtual care models and programs to improve patient experience and outcomes. Sandra is a registered physiotherapist with a Bachelor of Science in Physiotherapy from Queen's University and a Master of Arts from Central Michigan University. So her talk today is virtual remote care management COVID experience. So take it away, Sandra.
Good afternoon, everyone. I'm just trying to find out how to get my video on here from the other. So, there we go. Okay. So thank you very much for having me today. And I just wanted to give you a little bit of context of the work that we have been leading and working with partners in terms of our experience with COVID and virtual care. Just as a note, many of you know that the Ontario Telemedicine Network is now part of Ontario Health. So we have been integrated into that organization as of April 1st. And we've had some reorganizations within Ontario Health. So the work that I do now is in the portfolio in Ontario Health under population health and value-based care. And so in that portfolio, which is led by Ed Brown, we still focus on virtual care, but also we'll be working with OHTs and primary care. So it's a really interesting time to be able to look at how we can influence the landscape around virtual care going forward from a provincial level. So I'm just going to talk a little bit about, many of you are familiar with the work that we have done with partners over the years in terms of Telehome Care. So Telehome Care is a program that's been around for over 10 years. It's a 6-month remote patient monitoring program and health coaching for patients with COPD and congestive heart failure. And we have seen lots of work with our COPD patients. About half of the volumes that we see are patients with COPD. The focus of this program, and it's located, it's live in at 11 sites or in 9 LHINs across the province, is really to sort of support patients in their behavioral change around modifiable risk factors or modifiable behaviors in terms of their health. And we do this through the health coaching and monitoring of the teams, based it on evidence-based. So again, we use the COPD Living Well with COPD and all of those resources. We've worked extensively with your organization and clinicians over the years. Many of our programs have had RTs involved, as well as nurses, and the clinicians really focus and partner with the patients to really drive, support their personal goals in terms of their care, to really support that self-management approach. And really, the focus has really been to engage those patients in their care over their journey. At any given time, and this is some data from last year, we'll have about 1,300 plus patients on. So within the province, large number of patients are being supported remotely. And we have these patients check in with their team several on a daily basis, and also participate in health coaching sessions. So, significant work over the years to really be able to offer this program in a remote environment. And you can imagine, with all that's been recently happening, that programs like this have been really able to kind of get us thinking about other ways to support these patients and their care. And of course, one of the things that we always hear about from our patients is really, the ability to be able to have that close connection with their clinical team, to be able to support their care, know that there's somebody there supporting them, and also help them on their care journey. We've done some research on the program over the years with the University of Toronto, demonstrating the impact, being able to reduce emerge visits, and being able to really better support patients in their homes. So, and again, the patients really love it. And it's interesting because we always think the older patients don't do well with technology. And I think we're finding that even more now, that they do embrace it, and with easy to use technology and the support of a team, that programs like this really can have a huge impact in the care journey for patients. So what's happened recently? So of course, all that has transpired with COVID, and the focus across the province to really be able to switch very quickly within the health system from providing face-to-face care to remote care. We had several partners that came forward to us and said, how can we leverage this technology and the expertise and support of these clinical teams to be able to better support our COVID patients? So we had a couple groups that came forward to us and said, these patients, really, they're coming into our hospital, or we're getting referrals or from our assessment teams. And, is there a way that we can use this type of program and technology to be able to support the care of these patients so that they're not coming back into emerge and they're supported in their recovery in the community? And so we started working with a couple groups to be able to put together a COVID remote monitoring program. And as you can imagine, a lot of your patients who, have existing lung disease are really at risk. They're those vulnerable patients, and many of them have tested positive for COVID. So being able to leverage a program like this and a model of care to be able to support them was really, really key. And so we leveraged actually a bit of a different approach. We leveraged a bring your own device option where, patients could be supported on their own devices with a series of questions. So those questions were in terms of their temperature, their health, changing condition, and they were connected with the clinical team. And we got this program up and live with Michael Garron Hospital, so within the Toronto region, and as well as with a group out of the Central East LHINs that supports Lakeridge and Scarborough Health. So very quickly be able to get these programs up and running and really support the care. And the key components of this is, onboarding those patients quickly, having a monitoring team that monitors them twice a day, 7 days a week, and then have those key escalation paths to the programs or to the hospitals or additional medical support, so in those patients' condition potentially could be deteriorating. And, you know, one of the things that we had to do very quickly was really be able to turn these programs on in a very short period of time. So there was one group that we actually got going within a week. So really being able to look at, you know, how can we take an existing model? How can we, you know, really work with the team to co-design the questions we want to ask? And then, you know, how do we get these clinicians trained and be able to support the model very quickly? Many of the organizations you know, there was a shortage of O2 sat monitors, so many of those organizations started without that, but then were able to access them and to be able to give them to their patients so that we had additional data. So to date, these programs are still running. We've had, when we talk about escalations, this is where the clinical team who's monitoring are proactively picking up issues with these patients and being able to connect them with our other members of their team. In some cases, it could be a primary care provider. In other cases, it's an internal medicine or an ED physician to really, again, does this patient need to come to the hospital? And if they do, can we get emerge ready so that, again, you know, all those precautions are in place. And to date, we've only had 4 hospital admissions. So a really great way to be able to look at how we can support those patients in the community. And, you know, this is just a slide for you in terms of what patients are saying. You know, as you can imagine, a lot of the work that the clinicians are working with these patients, and they can communicate with them through the app, you know, for secure messaging, as well as they can launch a video visit. But a lot of those issues for those patients, they're quite anxious. So they found that this has been a great peace of mind for them. And then what that's led to is, you know, this sort of took off with the province. And we were able to actually work with the Ministry of Health to dedicate some dollars towards a funding initiative that would support COVID patients with clinical remote care in the community. And many of you may be involved with some of those projects. So they were funded through the 5 different regions in the province. So each region across the province has received some funding for different projects. Some of them are leveraging the existing provincial platform, which Ontario Health has available, but many of them are utilizing other technology solutions or care teams, which could include the community paramedics as one. There's some other COPD and hospital programs that are being leveraged. So a really great way to look at building on what was existing, how we can really leverage our lessons learned in terms of remote care and those care models, and how can we really be able to move that very quickly to be able to support a new group of patients at risk within the community. And so, Jessica, I think I'm right on time for that. So that just gives you a brief overview, and I'm happy to answer any of your questions as well.
Yeah, you're right on time. You have 42 seconds left. Yeah, so if anybody, I do have a question coming up here. Did all of these patients have a pre-existing chronic lung disease?
Not all of them, no. So some of them could be. It was designed for patients that required more medical management. So we know that with COVID patients, some people are positive but end up having no symptoms. And then there's a group that you know, obviously can become symptomatic and needed that medical management. So the groups that came to us were ones that were finding these patients were coming back into the hospital, or working with their primary care providers felt that they were at risk. And so that's the ones that have been onboarded to be able to support the medical care of these patients. Some of them definitely could have pre-existing lung disease for sure, but we didn't limit it to just that.
I was going to ask about as far as I think you addressed it a bit with working with people who are not tech savvy, but how has that feedback been for like a lot of the population who don't have readily accessible to computers or computer knowledge?
Well, and that's been an issue that we found with everybody switching to virtual care, is there's been a bit of a digital divide, right? So if you don't have devices, you don't have that internet support, can you still be supported? The nice thing about this platform that's available provincially is that we were able to have an option. So patients who have their own devices would be able to be supported again through the app. But there's also another option within that solution for patients who didn't have their devices could still be referred to the program. What would happen would be the clinical team, and some of those teams leverage some of their admin support, would instead of having the patients enter their data in twice a day, they would actually phone the patient. So they would phone them and ask those monitoring questions of those patients twice daily. Then that admin support would put the patient's answers, input them into the solution. So that would still generate alerts and trending data that would go to the clinical team, who could again follow up the patient by phone just to further assess their condition. So that was a really popular option for groups that said, what do we do about those patients who don't have a device and don't have access to technology? Can we still find a way to keep track of them and support them? And that was the nice option that we were able to offer them within this particular solution. But it's interesting, most patients were able to be supported through the technology, but we always do have some that we supported, through phone.
Perfect. Yes, I forget about the phone, right? That's a great tool to use. Does anybody else want to? Somebody had made a comment. Thank you for your talk. Great to see that this program is up and running. You mentioned there was research that was done in partnership with the U of T that showed reduction in emergency visits. Mm-hmm. And was this published?
So I think it's in the works to get published. There's always that delay to get it out there. But I do have an executive summary that sort of gives sort of a snapshot of what the research showed, that I'm happy to share with people as well. But it's in the queue to, last I heard, it's out there in publishing world to see if it's ready, if it can be published more widely. Yeah.
Okay, great. No other questions right now, but keep typing in your questions if you have more for Sandra, because there'll be time at the end to ask questions of everybody. I will get to introducing the next presentation. And so we have two people presenting. Tina Lepner is a registered respiratory therapist that graduated from the respiratory therapy program at Conestoga College in December of 2015. And shortly after graduation, she started working at ProResp in Kitchener. She completed her certified respiratory educator program in November of 2018. And home care has always been of interest to her, as she gets the opportunity to provide patient education and always hopes to have a positive impact in people's lives. And also we'll be hearing from Jennifer Nguyen. And Jennifer Nguyen is a registered respiratory therapist and certified respiratory educator at ProResp Kitchener as well. She is a graduate of Conestoga College and has been with the company since 2014. She has a knack for learning, most recently completing a tobacco cessation counseling course earlier this year in order to build upon her knowledge and confidence to help clients in the community. So thank you, Tina, and Jennifer, take it away.
All right, well, thank you for the introduction, Jessica. So today we'll be talking about our virtual care project with COPD patients. We will be discussing the program, what we have learned, and what our goals are going forward. So unfortunately, at this time, we do not have access to a webcam, but here are our pictures of Jennifer and myself. We are currently in the same room, socially distanced during this presentation. We do have to disclose that we have no conflict of interest. The pilot project started pre-pandemic last September 2019. We had no experience with virtual care prior to this, but we found that this was very easy to initiate and manage without any experience. We set up about 30 of our COPD patients at home that were oxygen dependent and provided a locked tablet using the Atonix A-Touch Away program. We provided teaching on how to use and navigate through the tablet. The Atonix program provides a variety of monitoring tools as seen in the picture below. For example, blood pressure cuff or scale, just to name a few. For the pilot project, we chose to use the Bluetooth pulse oximeter. The tablet was quite user-friendly. On the main screen, patients were able to access their contacts being us or their family. Patients were able to video call contacts just with the tap of a finger. The program also supported three-way video calls. Patients had the option of messaging their contacts as well. We were notified of any calls or messages from patients. This program allowed us to create workflows on the patient's tablet, such as daily oximeter readings that automatically sent results to her phone. The patient had to enter in the workflow if the reading was done on room air or on oxygen. We were alerted when oxygen saturations dropped to a specific number that we set ourselves. For an example, a saturation read of 85%. This allowed us to contact the patient if alerted and to determine if they required another oxygen flow reassessment or to remind them of oxygen compliance. Example, not increasing flows on exertion or not wearing it at all. Another feature of this program was that family could also be notified of oximetry results if they were added to contacts. This picture below is a simplified example of our daily respiratory status workflow. We would be notified if the patient was not feeling well. The workflow would prompt the patient to take the next appropriate steps, such as taking their rescue inhaler, antibiotics, prednisone, or contact their physician. The patient was also required to rate themselves on the MRC scale once a month just to track any changes. Another feature that this program allowed us to do was add customizable reminders. We worked together with patients to set these reminders. For example, reminders to take inhalers at a certain time or to use the aerobica daily. The program also had a resource library that the patient can access. It had videos and instructions on how to use specific inhalers, breathing and coughing techniques, along with breathlessness positions.
During our pilot project, there was some reluctancy to use new and unfamiliar technology for some patients who were not technologically inclined. We had patients who started the program and was hesitant to participate due to this reason. We were able to support and help them overcome these challenges by frequent education so that they were more comfortable. We ran into a challenge where most patients did not want to involve family with their virtual care. Part of the hesitancy was due to patients not wanting to be a burden to their family, or they were afraid that this tablet would take away from family visiting in person. Now, this was all pre-pandemic, and now during the pandemic, this program would allow patients to connect with their loved ones at a time when in-person visits were not recommended. This also allowed family to be more involved in the patient's well-being by seeing their daily saturation readings as well. As mentioned on previous slides, we were able to monitor the patient's daily O2 sat readings and respiratory status. By doing this on top of regular in-person visits, which was prior to the pandemic, we were able to have more touch points with our patients. This program also made it easier during the pandemic, where we were able to monitor and assess these patients when in-person visits were not recommended. Being a part of this program provided a sense of security for patients and improved communication with us. We had a patient who had an autoimmune disease that was terrified of in-person visits or leaving her home for doctor appointments. She was so thankful that we were very involved without having to come to her home. Although she was not being seen physically, she was very happy that we were able to provide virtual care. Patients reported that this program allowed them to increase their independence and self-management of their disease. So for example, a patient started off with daily reminders to use her aerobica device and inhalers as she was constantly forgetting. But after a few weeks, she asked for the reminders to be removed since she gained confidence that she will remember on her own. Because of our frequent touch points, we were able to have earlier interventions when a patient was not feeling well, which improved outcomes. An example was when a patient's respiratory status changed and she was feeling different. We were notified and were able to contact the patient. We were able to provide the appropriate intervention and encourage her to take her antibiotics, prednisone, and increase hypersaline treatments. We continued to monitor her until she felt better and reminded her to contact her physician. This early intervention prevented a hospital admission. Another example was when we were notified when a patient had poor daily oximetry readings and noticed that her readings were declining on her usual oxygen flow. We were able to contact her and arrange for an in-person assessment where she was encouraged to go to hospital and she was admitted. Moving forward, we hope to increase patient contact and introduce virtual care to all patients, not just COPD. Because we want to provide patient-centered care, introducing virtual care to all patients allows a stronger network of support for the patient. Depending on what diagnosis the patient has, we would be able to set specific goals, cater to them to achieve skills for self-management and improve quality of life. We plan on increasing the library of resources available on the tablet, such as more videos and pictures that are catered to the patient's specific disease. This program supports video calls and group chats, which could potentially allow the patient to connect with other allied health teams and informal caregivers, such as physicians, nurses, and loved ones. As we manage our patients, we can act as a mediator of information. So we can receive the alert and follow up with the client, get more information, make sure it's valid, and see the next steps. Then based on the information we have, distribute the alerts, for example, the low O2 readings received from the tablet to the appropriate person in the patient's circle of care. So for example, with our COPD patients, we can immediately update their respirologist with their health status. The quick response and real-time monitoring enables better outcomes for the patient. We will continue to monitor those on the program and provide early interventions to help triage hospital admissions appropriately. We hope to continue to learn as we integrate virtual care into our practice, and we want to reduce hospitalizations and increase patient independence.
Thank you for listening to our presentation. We will take this moment to answer any questions.
That's great. I have one question come in. What was your criteria for patients' participation? Example, was there a specific diagnosis, age, or comorbidities?
Yeah, so the main criteria that we focused on was COPD patients. So if there was a patient that was started on oxygen and they had a diagnosis of COPD, we would ask them if they would be interested in participating in the pilot.
Great. And how did you feel as respiratory therapists having this format to help your patients? What was the experience like for you heading pre-pandemic and then into pandemic?
It was definitely a different experience. I mean, it's very helpful. Prior to this, we found that a lot of clients were hesitant to even contact us by telephone, calling the office and then having us call them back. So by patients having a tablet where they could get a hold of us almost right away, or to send us a message and then, get our response within a few minutes, I think that was, I guess, easier for the client as well. But it just allowed us to have more touch points with the patient. So,
right. Great. Any other questions to come in? I'm not seeing any right now. How do you address privacy concerns? Was there any people concerned about using this and it affecting their privacy?
We did have a consent form that we had everyone sign prior to the project, where they were only, they would write down the names of any family members or any contact that they would allow for that person to be a part of the program as well. So we had everyone's permission prior to starting this pilot.
Okay, another question. Is this available only in certain regions or is it available everywhere?
Like this specific project?
I think that.
Yeah, we're just, we currently rolled it out just in the Kitchener branch right now. But we're hoping to have the other branches do it as well.
Right. Okay, great. I don't see any other questions right now, but please, as I said before, type in any questions you think of, and then I can ask them at the end. We will go on to introduce our next speaker. Maradine Haynes is a kinesiology graduate who attained her registered cardiopulmonary technologist certification, and worked at the Firestone Institute for Respiratory Health at St. Joseph's Healthcare in Hamilton in numerous clinical and research roles. She is a certified respiratory educator and tobacco counselor. Maradine took on the role of the tobacco program coordinator at St. Joseph's Healthcare, where she focused on the implementation of the hospital-wide tobacco program. She brought the CAMH STOP model of smoking cessation to St. Joseph's. Additionally, Maradine was the primary care asthma program coordinator at North Hamilton CHC, which is a provincial initiative for delivering asthma management in primary care. Currently, Maradine is the coordinator for the Caring for My COPD program, a community-based pulmonary rehab program at Compass Community Health. And I believe she will talk about how they've managed doing Caring for My COPD during the pandemic. So take it away, Maradine.
Yeah, thank you. So hello, everybody, and good afternoon. And some of you may have heard of Compass Community Health. We were formerly North Hamilton Community Health Center, and we rebranded a couple of years ago. So Caring for My COPD is a community-based pulmonary rehab program. We see about 250 clients a year into our PR program. March 12th, it's going to be one of those days where we knew where we were and what we were doing. Change is coming. We went from, going at 100 miles an hour to 0 in about 1 hour. So we had to prepare for the change. So at the onset of the COVID pandemic, we met with our clients and called them, and we suspended our on-site program for 2 weeks. And I believe now we're at week 35. So those 2 weeks have really lengthened for sure. So when we realized our program would be suspended longer than we first anticipated, the team got together and brainstormed to develop some strategies to support our clients. And we just asked ourselves one question: what do our clients need at this time from their healthcare team? So what we did was we started to meet weekly via Zoom because we were all off-site. We prioritized how can we meet the client needs, and so we developed some outreach strategies, which I'll touch on. And we adjusted to working from home, which for some people is challenging. If your spouse is working from home, you have kids that are home. So it was a bit of a challenge for a lot of us. The healthcare was great. They supported us with laptops, and we VPN'd access into the health center EMR so we could access client records, as well as our email. And honestly, we're sick of email right now. So the outreach strategies that we developed, the first thing we did was we had people that were attending the program when we had to shut it down in March. It's a 10-week program, so those I think we had 4 programs running. And so we identified those clients that were currently attending the program when it was suspended, and any other previous participants that we identified as high risk that would need ongoing support. From that, we created a master list, and we came up with 145 clients. And then the team divvied up those clients, and we called them every week from March 27th till June 12th. And we continue to call weekly quite a few patients, probably about 40 of that 145. And because we put so much work into it, we actually had the IT department evaluate the initiative with SurveyMonkey. Amazing feedback. We had 85% of clients fill out the survey. And basically what they did was, the bottom line was how much they appreciated and felt supported by the Caring for My COPD team in those dark days of March, April, May. So we were really pleased with we were able to make that much of an impact. We also gave the clients all our phone extensions. You have access to our work phone offsite as well. And to date, we have completed 1,655 calls. We started an initiative called COPD Chatter, and we invited our clients to attend the daily chatter groups for an open discussion. They were originally pre-booked, so we booked 3 or 4 clients in to join us on the chatter call, and we started that May till June, 24 sessions. And they were quite well attended. Again, I think it was because it was early on, May. So those went really well. And then on June 22nd, we moved to daily drop-in chatter calls, and one of the health team members facilitated those calls. They were pretty low attendance, so we actually ended up canceling them. So we contacted everybody and let them know that it would be canceled, and they could contact us the reverse way. So they could just call us as opposed to dropping in. So one of the really fun things that super proud of the team, we developed a Caring for My COPD email address, and we collected client email addresses with their consent on the weekly calls. And we began sending out daily emails at the beginning of May, and to date, we are still sending them out. 120 people receive these emails daily, and we have sent out 125 daily emails. Each team member sends out one email per week, and every day provides an opportunity to link with the clients, and they tell us they look forward to receiving these messages. And some of them are pretty innovative, to say the least. But we cover the basics such as exercise, community resources, COPD resources, action plans, nutrition, kind of all the standard stuff, vaccinations. But then we also throw in lighter topics. So we send out virtual tours for art galleries, libraries, zoos, countries, concerts, flash mobs, coloring, puzzles, you name it. We come up with some pretty funky emails that we send out. So we had a practice change. So it was an immediate change to virtual care, which, as the previous speakers have alluded to, were challenging for both the team members and the clients. The switch to working from home was a practice change. The switch to provide the Stop Smoking program to phone visits. So we gave them a curbside pickup option for their NRT, or we had home delivery, and we couldn't use Uber. We also had home delivery of Ensure meal supplements. And we had the PT would go out for a home visit if a client had a new injury, or we felt that they were a risk at falls, because we were moving to the actual virtual PR program. And the other practice change was Zoom training for clients, which we managed to do pretty well, actually. We had drop-in training sessions. We sent out a video. We emailed instructions, or we would actually put it in the snail mail for how that they would access our sessions. We also run a graduate support group, and we moved that virtually. Pre-COVID, they met weekly, so we went to online. Our kin student we're fortunate to have facilitates the sessions, and they socialize through a game of the week. And it's a lot of fun and pretty well attended. And we also moved to graduate exercise via Zoom, and we offer 3 sessions a week. So the move to virtual PR programming. So the past is gone, the present's where we are, and the present's probably going to be the future for us for a while. So what does Caring for My COPD virtual PR look like? So new referrals come in, the clients are called, invited to join the program. And our PR includes education and exercise. So both of those had a few challenges. So clients may choose to attend one on-site visit, and we do their 6-minute walk test and one-to-one exercise training session. They're provided with TheraBand and printed exercise guide for home use. They cannot exercise with us virtually unless they do attend this. And then we book once a week a one-to-one session with our EMR, and once a week in a group session. Or if, again, as speakers have alluded to, lack of technology, we'll actually call them and do their exercise over the phone, which is a little challenging, but everybody's caught on to it. Clients who do not choose to attend, they join the education portion only. We've lent out oximeters if people have concerning issues, and clients are supported for their technical needs. So Virtual exercise sessions to date, we've done 260 individual exercise sessions. We've done 46 Zoom group exercises, and you can see the attendees there. And we've done 40 Zoom graduate exercise sessions. We have over 500 people to date have attended that. So virtual education. So we had to make the change to ensure the seamless conversion to virtual care. The group program encompasses the variety of topics, so we kept those. The group runs with the understanding that clients need knowledge to manage, but beyond that, they need to feel connected and supported, and they need to believe that life can still be joyful and understanding that they do have hope. So we try really hard on our virtual education to get these messages across. And we've actually been surprised to find that the components have been pretty successfully delivered. And what we've done from now is we've moved to a 7-week group for mindfulness for our COPD graduates. And again, that's all virtual. So virtual education, we finished 6 cohorts that had started pre-COVID. We finished them virtually. We've done 5 new groups, all virtually, 400 classes, 240 people have signed on. So I'll just finish up with my last slide. Challenges we shall overcome. Some of the challenges, staff working off-site, virtually no face-to-face meetings. You really miss your teammates when you're, not sharing a coffee or a walk or something with them. Again, we've talked about this, access to technology. We try to support the kin student. We have tutorials. We have drop-in sessions, how to access Zoom, et cetera, et cetera. Challenges. So the client's new to using Zoom. We have to ensure appropriate conversations on the client side, if not muted, as you can imagine, some of the stuff we've seen and heard. Ensuring clients understand the commitment to virtual care, that it is their health care, not just sort of a drop-in. Clients' comfort attending on site for 6-minute walk. Of course, we've done all the necessary screening and PPE protection we need. Facilitating exercise over the phone. So we did a exercise safety sheet. Same as exercise over Zoom. Connectivity can be an issue. Angle of clients, we see their belly buttons more than we see anything else. Background noise. We can't really put a separate cardio element in there. And the other one is fostering a comfortable online community. And that's it. I think I came in under time. If you have any questions, I'm happy to take them.
That's great, Maradine. Thanks so much. I know how popular and well-regarded these Caring for My COPD programs are in the community. So it's amazing that you've taken it and shifted it to this virtual platform. That's awesome.
Yeah.
To see those numbers and to see how connected that keeps the everybody who's part of these groups. There's a few questions here coming in. You had mentioned canceling daily calls with the chatter group. Therefore, did you go back to the weekly calls then?
Well, at that point in time, it was June, and really the outreach helped the clients the most in March, April, May, and June. And because we feel the attendance for those daily drop-in chatter calls changed because sort of the environment out there changed. They didn't need the support as much. As I said, we probably call about 40 of them still weekly, and they are now on the Zoom graduate exercise, or they're coming to the mindfulness, and they can call us at any particular point in time. The first 3 months, all we did was spend time on the phone. And then when we moved to virtual care, we had to sort of give up some of that phone connectivity.
Okay. Great. And another question, just curious about the flash mobs. How was that created?
So we actually we can't take any credit for doing a flash mob. So we just found some fun flash mobs from across the world that were recorded on YouTube. So we just sent those out. We try to give people something light to look at, more than something, here's your action plan. So we intersperse those with a lot of humorous links to YouTube and meditation, stuff like that. I wish
Great.
we did a flash mob.
It would be hard to do a live one right now.
Yes. Yes, for
socially
sure.
distanced flash mob. Any other questions coming through for any of the speakers? You can type them in the Q&A now. I'll just see if we have any more coming through. I'm just looking back through. Okay. So I'll just then, I just was going to leave a few minutes for extra questions, but I don't see any more coming up right now. But I would like to just thank everybody for sharing your wisdom with us today. So to Sandra, Tina, Jennifer, and Maradine, we so appreciate your offering today, because this has been such a huge part of how care has been delivered, and I'm sure how care is going to continue to be delivered as time goes on. So we so appreciate that. Thank you to the planning committee for putting this together. There's a lot of work that goes on behind the scenes to do a talk like this, so we appreciate that. And for Gloria and Jennifer behind the scenes today, making sure all the technology works well, I really appreciate that. And please be sure to check out the Ontario Respiratory Care Society website for more information on the Better Breathing Conference that's happening. It's running virtually from January 18th to the 22nd. So that's where you will hear more sessions like the one that you've just heard. So I'm just looking if there's any more questions. Just thank you and great work, everyone. So just a lot of positive thank yous to the presenters today. So we really appreciate that. And that's all. I will end it there, and we'll see you at the next one.